Welcome to The Scope with Dr. K, where together we can reimagine GI care. Welcome to The Scope with Dr. K. I'm Dr. Kaczynski, and I would like to open the show as I always do by reminding everyone that the goal of this series is to present you a broad scope of value-based care issues, mainly involving the field of gastroenterology, but sometimes outside of GI as well. In each episode, we plan to bring you cutting-edge information through a focused interview with an influential and interesting key opinion leader. Our guest today is a longtime colleague and value-based research partner, Dr. Leanne Metcalfe. Dr. Metcalfe is the 2017 recipient of the Dallas Hidden Figures Award, the 2019 Stevens Young Innovator Award. She's a Rhodes Scholar finalist and a former George's Family Foundation Health Research Fellow. Her research work has been recognized by the U.S. Chamber of Commerce for 2 consecutive years in 2016 and 2017, with innovations leading to improved quality of health for both asthma and Crohn's disease patients. Her current research work is mostly focused on non-traditional impacts on health outcomes, including the social determinants and violence. Dr. Metcalfe is now a health economics consultant. She partners on academic research with insurance and Tier 1 research institutions. She is currently advising on private academic COVID-19 projects with the University of California, San Francisco. Good afternoon, Leanne.
Good afternoon. I love that intro.
I have a question for you. From the payer's point of view, why was it valuable for you to pursue joint research with a provider group? Can you expand on why this is useful for the payer?
Well, I think for both of us, the payer and the provider, the end goal is that patient or that member. And the provider might not have the full view of the patient, but the provider has the patient trust. So when we partner together, when payers and providers partner together, providers can get that holistic view of the patient. Where else are they going? What other specialists are they seeing? What else is going on in that patient's life, so that the provider can provide that holistic healthcare. And on the payer end, we're seeing now healthier patients that have better outcomes and better physical and financial health. Both of those things are really important to us. And you want to be sure that patient is completely covered from beginning to end. So yeah, that's why it's really important for us to do that partnership.
So if I could put it in my words, you use the relationships with provider groups to humanize the claims that you compile.
Yeah, and we can only see so much. We see numbers. We know that the patient went to the emergency room. The provider can say why. Why did this happen, and how do we get that information to the patient? They're not going to respond to a phone call from the insurance company, but you trust your provider, and your provider can help give you the information you need so you feel better.
Well, it was tremendously enlightening for me to be able to actually see complete claims data on patients that I was responsible for the care. We have no idea how much everything that we prescribe actually costs, and how what we prescribe relatively costs compared to other therapies. So yeah. It was enlightening. So I'm curious, how do you decide what conditions you focus on in research? What drove your decisions on what to study?
Well, you have different things and different inputs. So one of them, of course, is the data. And you look and you see, well, so many people have diabetes, so many people have hypertension. And so you look at the incidence and prevalence of certain conditions. But you can also look at the cost of certain conditions. Not too many people have IBD, not too many people have Crohn's disease or kidney failure, but the cost of treating those patients is really high. So you can either look at high cost versus low incidence rate, or a very high prevalence rate and a low cost condition. Some other times that we look at the provider. What is the provider seeing? As we're in a time of COVID right now, if providers were seeing certain trends, if something else was happening, the providers can help direct research in our way. and they can ask us to say, hey, have you noticed that people who have a certain technology that's in their offices tend to have patients that then go on to a certain surgery? So payers who are in the field also help direct our research because they're real time and they're seeing something. And then the last part of it is the employer groups that we insure. Because employer groups will come back and say to us, well, our employees are saying that they feel a certain way. The employees are saying that they see certain things. And that can also help us direct and build out different programs and research entities for large corporations. I think right now we get into a very interesting time because now people are working from home a little bit more. That changes the way you might deliver healthcare. So our employers are really big voices in this conversation. The providers are big voices in the conversation, helping direct what we want to study going forward in terms of how people approach the healthcare system.
The employer influence was something that I never realized as much as I did following our research that we've done together. I never realized that the majority of the book of business of most of the payers is self-funded employers. And they are bearing the risk in a lot of these, in most of the care provided. And so their needs do need to be heard. And as a provider, we almost never have direct communications with employers. And so I had no idea how important that was prior to the work we have done together at Blue Cross. So what type of things do the employers bring up to you?
Employers will look at their own spend in terms of what they're doing with healthcare spend, but they also want to be sure that their employees are feeling happy and healthy. So we'll either talk about mental health programs, how to manage stress at work, and do a lot of focus on the mental health side of things. But then we'll also look at considerations in the office. We may look at arthritis or osteoporosis type programs in the office, understanding how people connect with their systems, employees who are working on a line, and understanding what the healthcare access is for those members that work in large manufacturing plants. Because if they're in a certain shift and the doctor office isn't open, then how do those workers get access to healthcare? So we really do partner with a lot of our businesses to try to understand not just what does diabetes, hypertension do to their employees, but how are those employees accessing healthcare? How easy is it for them to access healthcare? Do we have a large enough network around there for those patients? And how do we connect them to a good doctor, either again in person or now we're talking about telemedicine services. So how do we do that so that those employees are happy and healthy and the employer has a good, happy, productive workforce?
Then you have to sell that to the plan to make potential changes that are necessary.
Yes.
One of the things you mentioned earlier when we were talking about how you decide which illness to study is you broke it out by cost. And one of the things that you and I have worked on over the years is our high beta illness concept, where we started by trying to figure out why the Sonar platform worked well in Crohn's. And Crohn's is a very high cost per capita condition. So you provided us significant support in this research. So what value did this project bring to HCSC?
So what is amazing about this project, we talked about the employer and the employer need, or even if we're looking at individuals on the exchange, just people in general who are dealing with chronic conditions. We always talk about care management programs, weight management programs that are supposed to help somebody manage their condition. What the high beta process showed us was that there were some conditions that had a huge variability in terms of outcomes and cost. And that helps us to direct services to those things that have that high variability. Because now we understand which conditions respond better to management and being well under control, and which are just really expensive conditions where no matter what you do, you'll just be really expensive. Maybe the drugs are really expensive. But for other conditions where you see those flare-ups and you end up in the ER, you end up in an inpatient setting, we're able to direct services that way. So you don't have so many care management programs that don't show results, but a small number of care management programs directed at improving someone's quality of life, reducing their financial burden, reducing the number of times they're in the ER in an inpatient setting, and just living a better life. Again, because we're focused on those programs where we can make that difference.
That's so critical. We so often as providers, especially specialist providers, are looking at patients as someone with an illness. Oh, this is a Crohn's patient. This is an ulcerative colitis patient. This is a acid peptic GERD patient. In actuality, this is a human being,
right?
Who happens to have one of those conditions and is balancing what this condition means to them in relationship to the rest of the aspects of their life. And early in the course of our research together, the finding that drove the development of Sonar was when we were looking at 21,000 patients worth of claims on Crohn's disease, and we looked at the hospital admissions, we noted that in the 30 days before a hospital admission, over 2/3 of the patients had no claims. Nothing. They went over the cliff. And the reason, it goes right back to what you were just alluding to. They're balancing everything in their lives. They have learned that they live with the symptoms of the condition, and they let those symptoms percolate up. If they have a condition like Crohn's, they get too close to that third rail and bad things happen. The second abstract that we presented at DDW this year stemmed from more research that your team and ours performed together on colon polyps. Polyps, of course, rise with age, but the rise with age is from right-sided polyps. This was groundbreaking to those of us who wrote the abstract because it was something that in medical school and in our training, we're taught that most polyps are on the left side of the colon. Well, looking at this claims data, they're on the right side of the colon if you're older. So what does the colon cancer screening space mean to you? Is this something that's a major concern to the payer? Is this something that needs more refinement?
If we're looking at this research, I know you look at cancer rates, and CDC predicted that deaths from certain cancers, including colon cancer, colorectal cancers, would be lower because of improved screenings and improved technologies. And so now we have this ability, especially with ICD-10, to really have an idea of what's happening within populations. And what's great about this is that we can use all of this information to continue to lower the mortality rate from colorectal cancers. Right, you can take any data that you have, and now we can refine this data even better to kind of direct resources. Say, all right, we know that this is happening. We're seeing it more. Do we create new technologies so that we can really understand what might be happening? I think, if anything, this research opened a door to even more investigation so that we can really drive these results and again, lower those mortality rates due to colorectal cancer.
If you just tuned in, you're listening to The Scope with Dr. K. My guest today is Dr. Leanne Metcalfe. So you steered us, Leanne, into the third abstract, but the second colon polyp abstract, because we were looking at race and ethnicity differences. And I was surprised that the percentage of African Americans in the screening population paralleled the percentage in the national percentages, but we saw 25% less Hispanics than the average population. So, this is a purely commercial population, and we're not dealing with, public assistance programs, but we're missing these folks. And so from a payer's point of view, are you focused on equality of screening? Is this something that drives your research? Is this something that is driving your policies?
Oh yeah, we have a huge, and this isn't, unique to Blue Cross. If you look across all of the insurance providers, there is a huge health equity, health disparities push to improve the healthcare of all individuals. And you can even see that now with all the discussions about mortality rates from COVID-19 and how it affects different races. So definitely where it comes to cancer screenings, we have had a push to be sure that minorities do get access to quality screening. What was interesting in this research is that it mirrored and paralleled what we were seeing with Latinas. So with breast cancer screenings, our rate of screenings from Latino women was a lot lower than any of the other racial groups as well. We did do some cultural surveys. We found that many women who are within a certain age are more focused on taking care of their children, taking care of their families, and less likely to go to the doctor to deal with something for themselves because they put everyone else first. There are other cultural issues that we know that we need to work through and figure out. It's when you're talking about health equity, you're still also trying to meet a person where they are and how they like to receive information. And so how do we message the importance of cancer screening to Latino populations in order to improve those screening rates for colon cancer, breast cancer, any of the other screenings that we really should be doing? In terms of the work that we've done for colorectal cancer in African Americans, and especially in Illinois, where the Blue Cross, the HCSC headquarters is, there's been a huge push since the mortality rate for colon cancer was higher for African American men. So there's a huge messaging going out to different churches, communities, in order to improve that screening rate. So we really need to be sure that we do the same thing for our Latino population.
On a different set of research that I've been doing, I've been looking at not only screening rates, but cost per capita for patients who present with colon cancer who were never screened. Mm-hmm. Like we say with COVID, the virus doesn't care whether you're Republican or Democrat or where you live. Colon cancer doesn't care who you are. If you don't get screened, it's going to have the same effect everywhere. And I pulled out the Illinois cancer registry data from 10 years ago and compared it to the Illinois cancer registry data from my most recent year I could obtain, which was 2017. And the stage at which patients present with cancer of the colon has not changed. It hasn't changed at all. And what this reflects are the unscreened patients, because the screened patients are not getting the cancer. Mm-hmm. It's the unscreened population. Now that population is smaller, but when we talk about colon cancer death rates falling, it's only falling because of the screening. Mm-hmm. The people who aren't screened are still presenting the same way they would have 50 years ago. And they may get better therapy today, but they're presenting with tumors that are penetrating the wall of the bowel or have metastasized elsewhere. And, in a commercial population, what bothers me is when I'm seeing less of a population be represented, because what bothers me is these should be people with covered insurance.
Yeah.
And they should have the same penetration into screening programs as anybody else. And it's probably multifactorial, and you're probably more of an expert about this than I am, but there's a human component where certain people may be reluctant to be screened or go in and get tested. There's access. Maybe they don't have a primary care doctor. Maybe their financial situation doesn't allow it, but it's very painful to look at that cancer registry data and see that it hasn't really changed.
Oh, no, access is absolutely huge. And when we looked at locations, so where providers were, where centers of excellence were, we talk about Illinois, or cancer centers for excellence tend to be on the north side of Chicago as opposed to the south side of Chicago. So you already have a small transportation barrier, a small access barrier for individuals to be sure that they go to a good facility to get screened and get the right treatment. So that's definitely something that we all need to work together, again, payers, providers, local health administrators, to be sure that we have good access and good coverage, or even just good transportation sources for individuals to get to the right doctor, the doctor that they need to see. But then similarly, we really need to understand, again, culturally, how do people receive information about healthcare? How can we encourage people to go out and get screened? We do know that some people respond to, hey, you need to be around to take care of your family. They'll go in that way. For someone else, it might be, hey, you'll look great and you'll live forever. So what are the key words that somebody needs to hear? What are the things somebody needs to see to inspire them to make sure that they go and get their regular checkups and get their screenings?
And we need to make it as easy on them as we can. I ran a study a number of years ago in our practice, and at that time we had 5 endoscopic ambulatory surgery centers in our practice. And I just looked at a simple metric. How old was the person when they came in for their first screening colonoscopy? And despite the fact that we tell people that they need to be screened at 50, the average age was 57 for women, 58 for men. So we're missing a couple of rounds of screening in this population. And according to our third abstract that we presented at DDW, we're seeing the same colon polyp percentages in the 40 to 50 age group as we are in the 50 to 60 age group. So we need to do a better job. Maybe this means different testing, and I'm sure my gastroenterologist colleagues won't like to hear that. Maybe we should be using FIT and some of these less expensive, easier tests so that we can capture a bigger population. But we've got to look at all these things,
Oh, yeah, and definitely. And again, this is where the payer and provider partnerships can come into play, because there are definitely payment policies, reimbursement policies on the payer side that probably need to be looked at as well, so that people aren't paying so much out of pocket for what could be a life-saving screening. But, if you go in for your screening and something is found the first time, then every other colonoscopy thereafter is out of pocket. So you have financial drivers that may be keeping somebody away from getting a screening. So how can payers and providers work together for, again, the physical health and the financial health of the patient, so we have really good quality of life outcomes?
Well, I've appreciated having you on today, Leanne. I think you and I could probably talk for a couple more hours on this. You can learn more about the show on the programs page of healthcarenowradio.com, and lend your voice to the conversation on Twitter at #HCNNowRadio. And be sure to follow us on Twitter at SonarMD. I'm Dr. Kaczynski. We're bringing patients, providers, and payers together to reimagine GI care. Until the next time, I'm Dr. K.